Okay, I think that's it. Okay, well, good afternoon, everyone, and welcome to Teaching for Today. I wanted to talk today about splenomegaly in children. It's not a topic we discuss very often, but we see it so often. And I thought it was interesting to discuss it from the point of view of the anatomy and the physiology and the pathophysiology of the spleen and splenomegaly and its functions, just so as we have an understanding of all the aspects of splenic function. Is a very important organ within the body. The spleen has two main functions, broad functions. One is to clean the blood, and the other one is to provide some contribution to the immune system of the body. So it has a blood cleaning function, and it also contributes to the immune function, especially the B and T cell immune function, and to cleaning out antigens from the blood. So we'll talk about those two functions. When you think about the spleen and what it does, they're the main two things it does. It filters out microorganisms, bacteria, especially bacteria, certain sorts of bacteria, lots of proteins that are in the blood, and also altered red cells. When red cells reach the end of their lifespan, which is about 120 days, then they get filtered out by the spleen. The spleen, I'll just move this and just show you. But the spleen, as you know, is located in the left upper quadrant. This is a CT scan of the abdomen, looking fairly superior in the abdomen. You a large liver on the right side. This is the kidney coming into view, and there's the spleen here, just here, and you can see this is the spleen. It looks about the same consistency as the liver. This is a non-contrast picture. When you get to a contrast picture, this is when you add contrast to it. You can see how vascular the spleen is. It's highly vascular. It's protected. This is a sagittal section, and you can see that it's protected by this fibrous capsule, and it also has some fibrous sort of strands within it that give the spleen its shape and its integrity. As I said, it's a highly vascular organ, the spleen, and it takes up to 5% of the circulating blood volume every minute. So a large volume of blood goes through the spleen, which is cleaned, and it enables the spleen to have some immune function protection for the blood. The spleen takes 5% of the blood volume every minute, but if a child or a patient is under a lot of catecholamine stress, they've got a severe infection, or they've got, for example, hypovolemia, then under any catecholamine stress, whether it's trauma or anything, then blood can flow out of the spleen into the active circulation. So all of that blood that normally collects in the spleen can then augment the intravascular volume of the circulation. So it's one protective mechanism for shock. For example, if a child's under a catecholamine surge, some of that blood can enter the circulation. So the spleen is somewhat of a vascular reservoir that retains blood, and then it can get out into the circulation if needed. But the blood continues to circulate, of course, through the spleen constantly. When you look inside the spleen, there's a number of different components, and one is the white pulp, which is this is the internal part, and that's where all the immune system cells are, especially B and T cell lymphocytes. And when blood goes through the spleen, then they get exposed to B and T lymphocytes. And as you know, the B cells and the T cells have somewhat different functions. The B cells produce antibodies. The T cell lymphocytes are involved in the production of cytokines that can stimulate antigen antibody complexes that can lead to phagocytosis with macrophages and neutrophils. So the spleen has a white pulp, which is the lymphoid tissue within the spleen, and it has a red pulp, which is more the vascular component of the spleen, and that's around the periphery of the spleen. So blood flows through the splenic artery into the spleen, and then there are vascular sinusoids, which are like pools of blood within the spleen, and those vascular sinusoids have they take blood. They're not like blood vessels. They're like very large lakes of blood, and the blood can sit there and then be cleaned and enter back into the endothelium cells, back into the splenic veins, and then out through the splenic vein. There's in between the white pulp, which is the lymphoid tissue, and the red pulp, which is all the vascular tissue, is a marginal zone. And in the marginal zone are a lot of the innate immune cells, like dendritic cells and macrophages. And so as blood is flowing through the splenic artery, then it goes into the white pulp and then into the vascular sinusoids and then back into the splenic veins. Then it gets exposed to all these immune cells, these dendritic cells, the macrophages, the B and T lymphocytes, and the immune system can do its job in terms of cleaning the blood. In this marginal zone, if there's antigens or bacteria, they get exposed to B and T lymphocytes. If there's antibodies there against those antigens, and they combine with the antigens, and the spleen also has complement, which is required for the opsonization of antigen antibody complexes that then can then lead to the macrophages phagocytizing the antibody complexes. So all of this happens because of the continual circulation of blood through the spleen, the splenic artery, the vascular sinusoids, through the white pulp, exposure to the immune system cells, the clearing of all the bacteria and the aged red cells and any other antigen particles, protein particles that might be toxins. So the spleen has a very important blood cleaning and immune function. I'll just show you this again. This is the splenic artery, and this is the white pulp here in the center. There's around that is the marginal zone that's got lots of dendritic cells, and inside the white pulp are all the B cells and the T cells, and then the red pulp is around here, and the vascular sinusoids, which acts as sort of blood collecting spaces. The vascular sinusoids are very important for the clearance of red cells. That's old, aged red cells, or red cells that are abnormally shaped. They get cleared as they're trying to get back into the capillaries of the spleen. So from the vascular sinusoids, they have to get back into capillaries and then into the venules and then into the veins and out through the splenic vein. But if there's old red cells that are damaged, once they're in the vascular sinusoids, they get phagocytosed by macrophages because they can't get back into the splenic veins. I've just mentioned this, but when this is a photomicrograph of the vascular sinusoids, and you can see lots of red cells and lots of white cells and macrophages there. And if there's red cells that are out of shape, then they can't pass through the slits in the endothelium to re-enter the capillaries. They're just sitting in those vascular sinusoids. And so any red cells that are deformed because of either they're old and deformed beyond 120 days, or if they're deformed because of some abnormality, congenital abnormality in their shape, such as if a patient's got spherocytosis or elliptocytosis, those red cells are abnormally shaped, or if they've got sickle cell disease where they're shaped like a sickle, or even thalassemia where there's abnormal shapes of the red cells, then those red cells can't get back from the vascular sinusoids into the capillary, through the capillary endothelium, the slits in the capillary endothelium, and so therefore they get phagocytosed by macrophages and other cells within the spleen. The spleen, in terms of its position within the abdomen, as I said, it's in the left upper quadrant, and it's tethered to the left upper quadrant by a whole lot of ligaments. And the ligaments help to tether the vascular supply, and they help to tether the spleen in the location in which it sits, so it doesn't just spread around the abdomen. But if you've got an inadequate number of tethering ligaments in the spleen, which some people have, they're born with an inadequate number or structure of the spleen, the tethering fibrous ligaments surrounding the spleen, then they have what's called a wandering spleen. And the wandering spleen really is just a spleen that is a bit prone to torsion. So it's a bit like a malrotation of the bowel, where if the bowel is not tethered down by the ligaments, then that can undergo torsion. In the same way, the spleen can undergo torsion, and it can tort around the vascular pedicle. If you think about this, this is the vascular pedicle of the spleen, and if the spleen is not tethered down, then it can move in, it can twist around the vascular pedicle, and if it twists around the vascular pedicle, then you can have an infarction of the spleen. A wandering spleen, a spleen without adequate vascular fibrous tethering of the spleen, occurs in about 2 per 1,000, 0.2% of all children, so about 2 per 1,000. It's not very common, of course, but if you have a patient who's got a lot of left upper quadrant pain, then and evidence of an infarction on ultrasound, which I'll show you a bit later, then it could be because of a wandering spleen. If the spleen's not in the right place, it might be because of what's called a wandering spleen. Some people have accessory spleens. They have additional lobes of their spleen. That's just a congenital abnormality. It's usually not consequential. Then there are other conditions that are consequential. They are associated with abnormalities, and one's called polysplenia, and that's where there's often a spleen on both sides. It's polysplenia is sometimes called bilateral left-sidedness, which means that on both sides of the body is the same structures as the left side. So for example, there's two spleens, one on each side, or parts of the spleen, one on each side, on the left and the right side. Each lung has two lobes, like the left lung, instead of having three lobes on the right, an upper, middle, and lower lobe on the right, there's two lobes. This is a congenital abnormality of just development, where there's what they call polysplenia or bilateral left-sidedness. The superior vena cava, usually comes down the right side. It may also be on the left, or the inferior vena cava might be interrupted. Instead of coming up the right side, it might be interrupted and then go through the azygous vein. So there's a whole range of vascular anomalies that mean that there's the structures of the body are a bit more like the left side than the right side. And then the most consequential part of that in a child with polysplenia is that they sometimes have cardiac abnormalities, so ventricular septal defects or other more serious cardiac abnormalities associated with polysplenia. There are also some children that have asplenia, and they're congenital. They have a congenital absence of the spleen, and that's again usually associated, not always, but usually associated with other cardiac abnormalities, especially cyanotic congenital heart disease, transposition of the great arteries, or total anomalous pulmonary venous drainage. They're both associated with asplenia, but asplenia can occur just as a de novo abnormality without any other genetic abnormalities. And some children with asplenia present with overwhelming bacterial infection with septic shock. That's a relatively common presentation of asplenia. We all sort of know what a normal spleen is. The size of a normal spleen is like. If you can feel a very large spleen, then we know that's splenomegaly. But there are rules for how big a spleen should be in a child. Now, about 5% of all children have a palpable spleen. Certainly about 5% of all children, and up to 30% of newborn babies have just a palpable spleen. But if it's palpable, it'll just be typical. It won't be a large spleen. It won't be a very large spleen. The normal spleen size for children up to the age of 3 is up to 9 centimeters. The normal spleen size for between 4 and 10 years is somewhere between 6 and 11 centimeters. And the normal spleen size in an adolescent is somewhere between 8 and 13 centimeters. The upper limit of normal for adults is 14 centimeters. And so there is an algorithm that you can say the spleen length is 6 centimeters plus 1/3 of a centimeter per year of age in addition to that, right? So if you just work out what the age of the child is, then it's that times 1/3 plus 6 centimeters. That will be the upper limit of normal. And of course, that's not the spleen that's palpable below the left costal margin. That's the spleen size on its largest length, its largest diameter, usually measured on ultrasound. And so you can measure the spleen on ultrasound and then see if the spleen is larger than that. 6 centimeters plus 1/3 of a centimeter per age of the child. So a child who's 3 will have the upper limit of normal will be 6 plus 3, so 9 centimeters. Right? So that's a way you can understand the normal largest length, largest diameter of a spleen. And remember, that's not what you measure from the left costal margin. That's what you measure if you're doing an ultrasound. So mostly we say a spleen's large because we can palpate it, but it's also good to do an ultrasound and measure it. There's a difference between splenomegaly and hypersplenism. Splenomegaly is just an enlarged spleen. It's anatomically enlarged. But hypersplenism is where there's splenomegaly with an increased function of the splenic function, right? And so an increased phagocytosis of one or more of the blood cell lines. So either there's anemia, leukopenia, or thrombocytopenia. So one of those, it's usually thrombocytopenia. That's very common in hypersplenism. And because of that, the bone marrow is increasing its production of red cells or platelets. And so you get the precursors of those cells in the blood. And so you'll have a high reticulocyte count or a lot of immature blood forms, or you'll have some immature platelets, which you usually can't see. But so the patient will be thrombocytopenic or leukopenic or anemic, and usually one or two of those problems, and they'll have a large spleen. Just to make the distinction between splenomegaly and hypersplenism. We see a lot of both of these things, but not everyone who has splenomegaly will have hypersplenism, but many children will. The most common cause of hypersplenism in children is malaria, and this hyperreactive malarial splenomegaly, HMS, it used to be called TSS, or tropical splenomegaly syndrome, results from repetitive episodes of malaria in a sort of chronic low-level state, and that produces an abnormal immune response where there's a massive increase in immunoglobulin M, and that leads to an immune complex. So immunoglobulin M is an antibody that combines with antigen, and then that has to be removed by the spleen. Antigen-antibody complexes are usually removed by the spleen with the aid of complement and with the aid of macrophages and other phagocytosing cells. But because of that, the spleen has to be increasing its function, and then it enlarges markedly. In many countries where HMS is very common, then they can measure the IgM, and you find that to be very high. And when you treat tropical splenomegaly syndrome or HMS, then the IgM level, the IgM level in the blood comes down back to normal. That because the spleen enlarges so much, then there's also the other reason for its enlargement is that you've got a lot of infected red cells. Remember I said if you've got an abnormal shape of the red cell, then they will have trouble getting back through those vascular sinusoids into the endothelium that lead to get into the splenic veins and back into the circulation. So if there's parasitized red cells, then they'll get stuck in the spleen and won't be able to be removed. And they'll also need to be phagocytosed as well by the macrophages and the granulocytes with dendritic cells within the spleen. So you've got two reasons why a child who has chronic malaria infection has a hyperreactive spleen. One is to remove the damaged red cells, the parasitized red cells, and the other one is to remove all the antigen antibody complexes that occur because of high levels of circulating immunoglobulin M, IgM. And that leads to, as you know, massive splenomegaly, often thrombocytopenia, because the platelets also get consumed within a large spleen, sometimes leukopenia, a very marked increase in IgM, immunoglobulin M, and certainly in some countries that's part of the diagnosis of tropical splenomegaly syndrome is to measure IgM. But I think we can make the diagnosis just as well by the clinical syndrome of a very large spleen with anemia or thrombocytopenia and leukopenia in the setting of a child who's got chronic malaria syndrome. The treatment of tropical splenomegaly syndrome is, first of all, treat the malaria, and that requires artemether, lumefantrine, the standard treatment for the treatment of malaria, and then malaria prophylaxis. Now, what's recommended at the moment is proguanil, simply because of the resistance of chloroquine, and proguanil would be a more favorable drug usually to be given on an ongoing basis. You often have to treat for many, many months to see any change in the size of the spleen. But if usually after a couple of months of treatment with proguanil, daily treatment, then the IgM levels will fall and the spleen will come back to a normal size. So that's just remember the main things are it's the increased mass of parasitized red cells and the IgM that leads to splenic overreactivity, hyperfunctioning, and that has a secondary consequence of low platelets and leukopenia and splenomegaly, and often hepatomegaly too, because the spleen's so large, there's vascular congestion within the spleen, and that flows back into the portal vein and then can lead to the liver being large and there being an element of portal hypertension related to that. Besides malaria, there's many other infections that can cause splenomegaly, and often we ascribe splenomegaly and hypersplenism mostly to malaria, but you can see obviously splenomegaly with other infections, especially Epstein-Barr virus. That's a classic cause of splenomegaly. Glandular fever. Most children, most adolescents have an enlarged spleen. Cytomegalovirus too can lead to an enlarged spleen. And of course, HIV. That also results in splenomegaly often. There's many bacterial infections that can lead to an enlarged spleen. So think of viral infections, bacterial infections, some fungal infections can lead to a large spleen, and then of course malaria. In terms of viral infections, then there's three main types. One is bacterial sepsis. So in a child who's got severe generalized sepsis, they can have a large spleen. Tuberculosis, though, can lead to lots of micro abscesses within the spleen. And it's something that we don't often look for, but we probably should in a child who's got miliary TB or abdominal TB. One marker, one thing in favor of tuberculosis in those children with suspected abdominal TB or suspected miliary TB is multiple splenic abscesses. Of course, the splenic abscesses could be due to staph or something else, but usually with TB, it's micro abscesses throughout the spleen, which you can see on ultrasound. This is actually a splenic abscess that you can see here. A splenic abscess will look hypoechoic, right? Hypoechoic, and there'll be usually a capsule around it. So multiple hypoechoic lesions within the spleen. You can see here, this is a child who had TB, who had multiple hypoechoic splenic abscesses. This is a larger splenic abscess, which you can see. Sometimes you can see splenic abscesses in children who have infective endocarditis, for example, bacterial infections on their left side of their heart valves, they are quite likely to have embolization, and it commonly goes to the spleen and the kidneys and the gastrointestinal tract, as well as sometimes to the brain. And splenic abscesses can often be seen in these patients. Again, the blood and the bacteria get lodged within the spleen, and if that overwhelms the immune function of the spleen, then you can have a splenic abscess develop. These are microabscesses also in tuberculosis. You can see this is miliary TB, and there's microabscesses within the spleen. So again, if you get a child who you think has suspected tuberculosis, then do a spleen ultrasound, and you can sometimes see that. Besides, so we've talked about malaria causing splenomegaly and hypersplenism. We've talked about other infections like Epstein-Barr virus, particularly glandular fever, and bacterial infections, and splenic abscesses, both with microabscesses from TB and from splenic abscesses from just other bacterial infections. But there's other disorders that can also cause splenomegaly, and one is just any one of the hemoglobinopathies or red cell defects. So if you've got a defect of if you think about a red cell, they've got a membrane. Sometimes there are defects of the red cell membrane, such as spherocytosis or elliptocytosis. Sometimes there's defects of the red cell enzymes within the cell, such as with G6PD deficiency. Sometimes there's defects within the hemoglobin itself, which is within the red cells, so thalassemia or sickle cell disease. All of these conditions, these congenital red cell abnormalities, congenital anemias, will lead to, or inherited anemias will lead to an abnormal size or shape of the red cells, and that will lead to more of the red cells being blocked within the vascular sinusoids of the spleen, not being able to get out and being phagocytosed, and then the spleen increases its function and increases its size. And so here's a child who's got sickle cell disease, and you can see the abnormal size and shape of the red cells and some sickling of red cells. But this could be any child who's got any form of hemolytic anemia where there's abnormal size and shapes of red cells, which lead to more red cells being blocked in the spleen and therefore the spleen enlarging. If you were to do investigations, again, when you're thinking about what's the cause of a child's splenomegaly, then there are certain clues just on basic investigations. So what would be in favour of a red cell abnormality on the full blood count that caused splenomegaly would be if there's anemia, and if there's increased reticulocytes and an increase in bilirubin, and then if you saw abnormalities of the red cells, like in this blood film. On the blood film, if there were schistiocytes or damaged red cells, or spherocytes, or that their spherocytes are abnormally shaped round red cells, or poikilocytes, which is these are poikilocytes. They're just abnormal shaped red cells. So if you don't see sort of a uniform blood film where the red cells just look like their normal spherical appearance, then it might be the child's got a genetic form of anemia, such as thalassemia or G6PD deficiency or hereditary elliptocytosis. They're relatively common in PNG, and they will cause splenomegaly. Also, if you saw abnormal shapes and sizes of red cells, then sometimes that's an autoimmune hemolytic anemia, which can occur with lots of different infections. So Mycoplasma can give an autoimmune hemolytic anemia, particularly. So can Epstein-Barr virus sometimes lead to an autoimmune hemolytic anemia. And so there's many different hematological causes of splenomegaly that you need to go through. If you see a child who's got a very large spleen, don't always think it's malaria. It could be malaria, it could be EBV, it could be a splenic abscess, microabscesses related to TB, a hematological disorder, for example, or it could be a malignant cause of splenomegaly. And you'll all recognise that acute lymphoblastic leukemia or even chronic leukemia can lead to a large spleen, or a lymphoma can lead to a large spleen. And again, we can make these distinctions with just basic clinical examination and looking at the blood film. So typically, of course, there'd be other lymphadenopathy and hepatomegaly as well. And there'd be a high white cell count, and there'd be anemia and thrombocytopenia. Now, sometimes these blood film changes, anemia and thrombocytopenia, occur with some of the other things I've mentioned, with hypersplenism or with hematological disorders. But of course, always think, could this child have leukemia? Do they have other mass disease, a big liver, a mediastinal mass, lymphadenopathy, as a pointer? What would be in favour of this being leukemia or lymphoma? And then beyond infections, beyond hematological conditions, and beyond malignant causes of splenomegaly, then consider that the child might have portal hypertension. And sometimes that's primary and sometimes it's secondary, but usually there's a problem. Portal hypertension, to understand portal hypertension, you need to have some understanding of the flow of blood that goes into the liver and where it comes from, and why the blood pressure might be high. Usually the portal vein is a very low pressure system. Remember, most of the blood from the portal vein is coming from the bowel. It's bringing the absorbed food, nutrients that we eat gets absorbed, the nutrients get absorbed, and then they go through the superior and inferior mesenteric veins to get to the liver to be purified. Remember, the liver has a purification role as well. And when the blood flows back into the liver, it's usually under low pressure. But if there's, for example, as one example, if there is a clot in the portal vein, if there's an obstruction to the portal vein, then the pressure in the superior and inferior mesenteric veins and in the portal vein itself will be very high. And so will the pressure in the splenic vein, right? So the splenic vein drains. Remember, we said the splenic artery goes into the liver, goes through the white pulp and the red pulp and the vascular sinusoids, and then comes back through the splenic vein and then comes to the liver. So all of that purified blood still has to go through the liver to be purified a bit more before it can go back into the right atrium and then into the pulmonary circulation and then back into the heart and through the systemic circulation. So that the reason for that is there's several stages of purification of the blood that comes from our bowel and comes through our spleen back into the liver for this additional step of purification. But if there's a clot, if there's some obstruction to the portal vein, then the pressure inside the splenic vein and the mesenteric veins will be much higher, and that's portal hypertension. And that can occur because of any increase in resistance in the portal vein. And you can have increase in resistance in the portal vein because you've got a clot in the portal vein that will increase the downstream resistance. But it can also occur, of course, if you've got, for example, fibrosis of the liver. If you've got fibrosis of the liver, then the portal vein, then there'll be increased resistance within the liver, and therefore that will flow on to increased resistance into the inflowing blood vessels that come to the liver, usually the portal vein, and that will lead to portal hypertension. So anything that causes disease of the liver, fibrosis, or portal vein thrombosis, or a cavernoma, which is a congenital vascular abnormality of the liver, or liver cirrhosis, that will all lead to portal hypertension. Most children who have portal hypertension will have a history or the clinical features of liver disease. That will be in favour of it. Sometimes children have an isolated portal vein thrombosis, And that's much rarer than chronic liver disease, chronic liver cirrhosis causing portal hypertension, but sometimes it'll occur. You can usually see portal hypertension on ultrasound of the liver and the spleen. And the way you can see it is the portal vein is very widely dilated. If you think that if there's a clot here, then the portal vein leading into it will be widely dilated because it's under pressure. And so that can be seen. Here's an ultrasound of the liver, and this is an enlarged, widely dilated portal vein. This is the gallbladder, but this is the portal vein. It's widely dilated. And this is the normal architecture of the liver, but the portal vein is dilated. So there's something wrong with the liver or something wrong with the portal vein leading to a widely dilated portal vein. And in the setting of a child who had a large liver and a large spleen, that would be consistent with portal hypertension. In this child also had portal hypertension, but it was related to liver cirrhosis. And you can see that the echo texture of the liver is just different to here. See how it looks relatively smooth? Well, see here it looks rather nodular. The edge looks nodular, and it looks like there's a more coarse echo texture within the liver, and that's liver cirrhosis. And that also leads to portal hypertension because the blood flowing into the liver can't get in as freely as it normally would. So therefore the blood pressure backs up in the portal vein and then the splenic vein. That's portal hypertension causing causing splenomegaly. So again, when you've got a child who has splenomegaly, you should think to yourself, do they have also hypersplenism? And are there features of hypersplenism in their blood film or their clinical features? And if they've got hypersplenism and splenomegaly, what could be the cause of the splenomegaly? And go through that list of causes I've just discussed and think to yourself which one is most likely. Again, if they've got liver disease, it's more likely they've got portal hypertension. But if they've got other clinical features, it may be more likely they've got something else. The other thing, in the same way that a spleen can be congested because of portal hypertension, because of the back pressure of blood, a spleen can also be congested because of heart failure. And sometimes, it's not common, but sometimes if you've got chronic heart failure, that can lead to splenomegaly just because of congestion, just like you can get hepatomegaly as well. So a big liver and a big spleen sometimes occurs in heart failure. I think it's quite rare, actually. And even though it can occur, if you've got heart failure and splenomegaly, then you should also look for other causes of splenomegaly, like an inflammatory cause or an infection or hemolytic anemia. It's more likely they've got some other cause of the splenomegaly than just the child's heart failure. And then there are some less common but important causes of splenomegaly that are immune dysfunction or autoimmune or inflammatory causes, like juvenile chronic arthritis or systemic lupus erythematosus, or there's a condition called hemophagocytic lymphohistiocytosis, or HLH, which it's not very common, but when you see it, it looks a lot like a child's got severe systemic inflammation or sepsis syndrome. So when you see this sort of thing, especially if a child's got arthritis as well or joint inflammation, then we always think of rheumatic fever, but there can be other conditions also causing splenomegaly and severe systemic inflammatory response. Usually the clinical features in favor of an inflammatory disorder causing splenomegaly are that the child's got a multi-system disorder. They often have arthritis or persistent fevers or red rashes, or they've got microscopic hematuria consistent with kidney involvement, like a nephritis. They often have a very high ferritin level. So if you can do their iron studies, their ferritin level will be extremely high, especially with this condition called HLH. And often their liver transaminases will be also high. So there are some clues. There are certain things in favor of an inflammatory disorder causing splenomegaly. So we've talked about malaria, other infections, splenic abscesses, viral infections like EBV, hematological causes, anything that leads to an abnormal size and shape of red cells, about malignant causes like leukemia and lymphoma, and now inflammatory causes and portal hypertension. So there's lots of different causes of splenomegaly. And when you've got a child with splenomegaly, you just work through what the clinical features are and what features are in favor of one or the other. I wanted to briefly touch on splenic trauma because there's been many children who have abdominal trauma have some degree of splenic trauma. It's actually the most commonly injured intra-abdominal organ in children. In any child who has an abdominal trauma, then they're likely to have some degree of injury to their spleen. Children are much more susceptible to splenic injury than adults. Adults are quite well protected by their fairly stiff rib cage, whereas for children, they've got a compliant rib cage, and also because of the way the diaphragm sits, then the spleen tends to protrude out a little bit more and be more prone to intra-abdominal trauma. You know, a child's abdomen is a bit more protuberant, and part of that is the way the diaphragm sits. And the spleen is more exposed to trauma, I would say. The ribs are more flexible, and compared with adults, there's a larger surface area of the spleen and the liver. So liver and spleen trauma is quite common. The younger the child, the greater the risk they are of splenic and liver trauma. What's changed about the management of splenic trauma is that it's very rare that such children benefit from an operation like a splenectomy. And it's really only if you've got a disruption of the vascular pedicle of the spleen. If a child's got a splenic laceration, then usually, and it's not causing major ongoing bleeding, then mostly these splenic injuries are managed quite conservatively without surgery. And the reason why that's valuable is because it's always good to keep your spleen. It's in the past, when splenectomy used to be done on a lot of patients with splenic injury, then there'd be many patients who would die later from overwhelming septic shock. And so now it's, of course, if a child's got a vascular injury that's just bleeding a lot, then sometimes that will require a splenectomy, and sometimes it will require some salvage surgery to repair the vascular tear in the spleen, and sometimes it'll require even embolization of one of the bleeding vessels, so that part of the spleen infarcts, but the rest of the spleen is present. These days, surgeons do everything they can to avoid taking the spleen out and to protect whatever spleen can be functioning. It takes a long time for the spleen to heal, though, at least 3 weeks, even with a minor splenic injury, and up to 20 weeks or more for if you've got a severely shattered spleen. This is a splenic laceration, and so this was this is a CT scan of a child. You can see the laceration there just in the spleen. This is this is a laceration in the liver, and over this side is a laceration in the spleen. And you can see that there's quite a severe injury to the spleen, but still this could be managed by conservative means, not requiring surgery, intra-abdominal surgery. And as I say, unless the child's in hemorrhagic shock from a bleeding vessel, and even then, the best thing to do is to try to repair the vessel. Splenic infarction can occur, I said, because of a torsion of the spleen. If a child's got a wandering spleen, it can occur because of a embolization from a left-sided intracardiac thrombus. So in a child with rheumatic heart disease who might be in atrial fibrillation, who's got a clot in the atrium or a clot in the ventricle, or a child who's got endocarditis with a vegetation on the valve, they can get splenic infarction. And remember I said that if you've got a left-sided clot, then you can have clots embolizing to the spleen, often to the kidneys, often to the bowel, leading to bowel infarction, and sometimes to the peripheries as well. So this is the telltale signs of multiple embolization in a child with infective endocarditis. You can see the red spots on the feet. This could be just because of thrombocytopenia, but it's because of showers of infected emboli going to the tissues. So that if you see that, then it's very likely there'll be emboli elsewhere in the body. It's common in sickle cell disease to have splenic infarction, but we don't see too much sickle cell disease. Usually it presents, the features in favor of splenic infarction would be left upper quadrant abdominal pain and tenderness. The child has a tender abdomen over the side of the spleen. They usually have fever and leukocytosis. Often their lactate dehydrogenase, LDH, will be very high if they've got a splenic infarction. And they may have these other features of embolization in other locations, such as the kidneys on CT scan, or the spleen, sometimes the brain, often the peripheries of fingers, hands, or the feet. So think of splenic infarction. If you do think of it, then this is the ultrasound of a child who had a splenic infarction. This is the spleen, and you can see the hypoechoic area. And if you put the Doppler on, then you'll see no blood going into that area of infarction. So there's a lack of blood flow to that area of the spleen. This was from embolization of infected vegetation from the left side of the heart, from the left ventricle, and you can see there's a large area of infarction of the spleen. It doesn't mean that the spleen will die. It's only that one portion that will probably die, and hopefully the rest of it will be preserved. I just said before that the indications for splenectomy are really rare these days, but they can occur if you've got marked hypersplenism and very severe thrombocytopenia. Always it's better to treat for several months with proguanil and see if you can get the spleen down. But if there's persistent thrombocytopenia leading to bleeding, then sometimes that's an indication for splenectomy. But usually it's very hazardous. The spleen is highly vascular, so after the splenectomy, there's an increased risk of bleeding because of thrombocytopenia anyway, and it's hazardous also because of an overwhelming infection that can occur after splenectomy. It can occur anytime after splenectomy, and it's really important that if any child's having a splenectomy, they get vaccinated against all the bugs that can especially cause septic shock if you've had a splenectomy. So Streptococcus pneumonia and Neisseria meningitidis and Haemophilus influenzae. Those three bacteria are very likely to cause infection in a child who's had a splenectomy or has asplenia for whatever reason. So if you're contemplating doing a splenectomy on a patient because they've got severe hypersplenism and it's intractable to all treatment, then they need to have the PCV, the conjugate pneumococcal vaccine, the Hib vaccine or pentavalent. They need to be fully immunized against that. There is a vaccine against meningococcus that patients should have if they're having a splenectomy. And also there's the PCV is a 13-valent vaccine, and it covers 13 serotypes of pneumococcus, but there's also a 23-valent pneumococcal vaccine, which children over the age of 2 years, they have a good response to. And so if you've got a child who's needing a splenectomy, then you can get hold of both these other vaccines to give them beforehand. They need to stay on antibiotic prophylaxis, so penicillin daily. And if they do that, if you give them all these vaccines and daily penicillin, then usually they're fine. They don't usually have any major problems. Sometimes when these days, instead of doing a complete splenectomy, there's a subtotal splenectomy, and that is the surgeons leave a small amount of splenic tissue, and you only need a small amount with a vascular supply to do the job of the spleen. And so that can be a way where the child retains some splenic function. Lastly, I think a number of children we see have dysfunction of their spleen. They might have a large spleen, or they might not have a large spleen, or they might have an absent spleen, but they may have some splenic dysfunction. And that can lead to an increased risk of infection. And you can assess a child to see if they've got a functioning spleen. So if you see a child who's got overwhelming sepsis, then the ways to assess a child's splenic function is, first of all, you can do an ultrasound to assess the presence of the spleen, just to make sure the spleen is actually there and make sure there's not some congenital abnormality of the spleen, not some area of infarction in the spleen, or not embolization of the spleen. So you can do an ultrasound to assess the presence of the spleen. That just tells you the anatomy is okay. Then you can check the full blood count for Hal-Jolly bodies. And now Hal-Jolly bodies are these are red cells in a patient with asplenia. And you can see these little, normally there's no nucleus in the red cells, but remember the nucleus of red cells is the red cells, when they start their life, usually before they're released into the circulation, they do have a nucleus, and then the nucleus involutes. But if you've got asplenia, then there'll be a lot more circulating red cells that still have a nucleus, and that's what these, well, still have these remaining fragments of DNA within the red cells. And that's what Hal-Jolly bodies are. They're just remnants of nuclear fragments within the red blood cells. And if you see a blood film that looks like this, then it's likely the child has asplenia or a hypofunctioning spleen. And that means the child is at risk of getting overwhelming sepsis with pneumococcus or Haemophilus or meningococcus. And so those patients should go on prophylactic penicillin, and they should have their vaccines. So I think just important, if we do see a child with overwhelming septic shock, think to yourself, well, could they have some immunodeficiency? Could they have asplenia? And that can be one thing to check. It's pretty easy to check. You do an ultrasound and you just look at the full blood count. All right, well, that's all I wanted to talk about today. We've talked a lot about splenomegaly and hypersplenism and all the different causes of an enlarged or hyperfunctioning spleen. And so I hope that's been useful to you. I think we often neglect the spleen, but it's a very important organ, and we should understand it a bit better. So that's all I want to say today. I'm going to stop the recording now and happy to answer any questions you have.